All right, good evening, everyone. Welcome to the second in a series of the webinars we're broadcasting from the NYU Langone Department of Otolaryngology, Head and Neck Surgery. My name is Paul Kwok, and I'm one of the ENTs in the department. And I'm delighted to be joined this evening by four of my great colleagues to talk about nasal obstruction and congestion in a discussion that we're calling today, How to Tackle the Blocked Nose. Undoubtedly, this is an issue that we deal with frequently as ENTs, but primary care providers may well be the first points of contact for patients who are dealing with difficulty breathing through the nose. So we're glad to see a lot of primary care providers in our audience today. Hi, guys. And we hope this hour will provide you with some information to help in managing these patients and knowing when we think we can be of help and of service to you. So first, some housekeeping. We're happy to field any questions as best we can during this webinar. So this software allows you to ask a question. If you hover, sometimes this is the bottom, sometimes it's the top of your window, that allows you to type a question to us. And we'll try to get to as many of these questions as we can through the course of this hour. All right, so on to the content. When you registered for this webinar, you probably noticed that we are very privileged to have two facial plastic surgeons on this panel and two rhinologists. And all four of these folks are faculty in the Department of Otolaryngology, Head and Neck Surgery here at NYU, but their subspecialty areas of expertise focus in this topic often of how to help with an obstructed nose. So I'm very pleased to introduce our panelists today, Dr. Richard Leibowitz and Dr. Seth Lieberman, our two rhinologists who are on today's panel. Dr. Leibowitz is the chief of the Division of Rhinology and the co-director of the Anterior Skull-Base Surgery Center. He also happens to be our program director, so he is in charge of our resident physicians and their education in the department. Dr. Lieberman is a rhinologist and a skull-base surgeon in our department and the associate program director. On paper, it's a little difficult to tell these guys apart. Even down to their names, which are homophonically similar. But we're pleased to have both of them to speak to their areas of expertise today. We're also very pleased to have two colleagues from our Division of Facial Plastic Surgery, Dr. Judy Lee, the Director of Facial Plastic Surgery, and Dr. Jeff Markey, a facial plastic surgeon who has a special interest in facial reanimation. And both of them also do quite a bit of work in the nose, and then infrastructure and surgical approaches to nasal obstruction. So it's a great asset to have both of these divisions represented because, as you probably have surmised, anatomic and functional considerations are equally important in evaluating an obstructed nose. These are our panelists, and you'll see each of them as they start speaking to you. We put together some content for them to walk us through. And we're going to start from the outside and go in. I think Dr. Markey is going to lead off and start talking to us about some of the considerations that come into evaluating an obstructed nose. Jeff, over to you.
Dr. Lee is going to start actually for this.
Oh, Dr. Lee is going to start. Very good. Judy, over to you.
Hi, thanks, Paul, for that introduction. Let's start with just some of the basic anatomy when it comes to the nose. The outer nose, what's visible to you, when you look in the mirror, the bony part is a pair of nasal bones that represent the upper third of the nose. And then the lower 2/3 or half of the nose are basically made up of two sets of cartilages. The septum, which is the internal partition between the nasal passages, is also made up of cartilage and bone and inserts into this sort of outer framework. If you look at the picture below, you can see just how expansive the septum is. It starts really at the tip of your nose and extends all the way back to the back of your throat. And so when we talk about deviated septum, it really is quite a large area. Of these four structures, any one of them could cause nasal obstruction depending on the shape or the configuration of the structure, but typically the one that's most commonly cited is a deviated septum. Now, deviated septums are very common. Oh, go back. Deviated septums are very common, can be found in, upwards to 70% of the population if you really look. And not all septums, not all deviated septums cause obstruction, and not all deviated septums require treatment. The previously mentioned structures are isolated structures that can cause obstruction, but when you look at it as a three-dimensional space, there's this concept of the nasal valve, which can cause obstruction, and is actually a very common finding if you really look. The external nasal valve is a three-dimensional space that pretty much is comprised of the nostril and the nostril patency. The internal nasal valve is more posterior or more internal, and it's a space that's surrounded by the upper lateral cartilage, the septum, and the floor of the nose and the inferior turbinate. Now, the internal nasal valve is the narrowest part of the nasal passage. It is going to be only a few millimeters wide, and a small change either by reduction or increase can make a profound effect on nasal breathing. And the nasal valve is a commonly missed diagnosis when looking at nasal obstruction, since a lot of people tend to focus on deviated septums, even among otolaryngologists or ENTs. These are just examples of external nasal valve obstruction, so i.e. the nostrils. If you look at the picture at the top, the nostril shape and configuration can lead to nasal obstruction, especially with inhalation. You can see on the photo in the bottom left that the nostrils are extremely narrow. This would clearly look obstructive, but even with the photo on the right, where the nostrils look seemingly large, you can have external valve obstruction, especially if it's a more downward pointing nose, and the nostrils, while shape-wise they're large, they're in an unideal configuration, and so it obstructs airflow. The internal nasal valve typically corresponds to the middle third of the nose, the midsection of the nasal bridge. It's usually where those upper lateral cartilages would suspend. And one of the telltale giveaways is that you'll see sort of a narrow pinching of the middle part of the nose. That usually implies that the nasal valves may be an area of obstruction, particularly in patients who have this symptom. And the picture on the right is just a endoscopic view of the internal valve. Typically it's very narrow with a narrow acute angulation, and in this situation it's completely obliterated. Now, as far as diagnosis, deviated septums typically are relatively easy to diagnose because one can look inside the nose either with an otoscope or some other light source and kind of get a sense that the septum is off of midline. Nasal valve obstruction is a little bit more nuanced, and a lot of times the patients will tell you that they have nasal valve obstruction by showing you what they do to try to alleviate the nasal obstruction. The Cottle maneuver is a way to pull out your cheeks or pull out the nostrils manually in order to get more airflow through the nasal valves. A modified version of this that you can do in the office would be taking either the short end of the cotton tip applicator or a small instrument and just sort of gently suspending out the lateral nasal wall or the nostril to see if that alleviates the nasal obstruction. This is a sort of easy way to do this in a primary care setting. There are objective ways to test nasal obstruction, rhinomanometry and acoustic rhinometry. I'm not going to spend a lot of time on that. Basically, these are ways to measure pressure going through the nasal passages to sort of determine resistance of the nose. And in acoustic rhinometry, you can use sound waves that bounce off of the nasal structure to get a sense of the three-dimensional space. And so these are objective ways to measure nasal obstruction. However, in practice, they're cumbersome, they're time consuming, and not widely practiced in most office settings. We have a number of patient validated questionnaires to look at how their nasal obstruction is affecting their quality of life. We won't get into this, but there's just a number of different questionnaire tools that have been developed over the years to get a sense of, how much is it interfering with their day-to-day. Moving on to treatment options for the external nose. Specifically, this is kind of looking at nasal valve obstruction. There are commercially available nasal splints, nasal cones, silicone cones. The picture on the right would be the Breathe Right strips that are found in most drugstores, where these are ways to get around nasal obstruction and to open the nasal valves.
Do we see this in the office setting a lot, and people try these popularly? How would you guide some of our colleagues on when to try these things, and when is it appropriate then instead just to send them to one of our offices? Do you have a way to guide people on that decision-making process?
Sure. I would say for the patient who comes in with a complaint of sort of chronic, constant, doesn't really fluctuate with day to day or seasons, nasal obstruction, feels like they can't get as much air through the nose. I think every patient should try, breathe right strips or something, particularly at night if the obstruction is interfering with their sleep quality. I think it's a very harmless thing to try. The impact that the breathe right strips, if it helps, it's great, but if it doesn't help, doesn't necessarily mean it's not a nasal valve problem.
Good. That was a really helpful overview, Judy. I think we're going to move now to talk about some of the surgical options that can become available to us. And Dr. Markey is going to take us through some of that discussion.
Yeah, thanks, Paul, and thanks, Judy. So now we'll talk about some of the surgical options. So you've seen a patient in your clinic. You've recognized that they have nasal valve collapse, or they have septal deviation, or they're complaining of not breathing well through their nose, not sleeping well at night, having poor exercise tolerance, even allergies, things like that. And so you've referred them on to either the Rhinology department with Dr. Lieberman or Dr. Leibowitz, or the facial plastics department with me and Dr. Lee. These are some of the things that we can do from the facial plastics point of view to ensure that the patient is breathing better after the referral. So first off, we're going to talk about the external nasal valve, which Judy talked about for a while too. So for the external nasal valve, there are certain surgical options that we have to ensure that the outer part of the nose does not collapse inward when they're breathing. And so their breathing is not obstructed. And so they can sleep better, they can exercise longer, things like that go along with breathing well through your nose. So some of the important points that we want to make when the patient comes and we diagnose external nasal valve collapse is we need to make sure that the nostrils are symmetric so the air can get through both sides equally. If one side's off to the right or off to the left, then the air is not going to get through that narrowed side. So we look at the nose, make sure that the nostrils are symmetric. If there are any anatomic obstructions, so if the septum is deviated to the right or deviated to the left, once again, make sure it's right down the middle so that the external nasal valve is not collapsing when they breathe. And lastly, which we'll talk about more in a minute, we can use the cartilage, which we often get from the septum. So if the septum is deviated off to one side, we'll make incisions inside the nose. We'll borrow that cartilage from the septum, and we'll use that cartilage, which was previously deviated and blocking the airway, as grafting material for supporting the external valve or supporting the internal valve, which I'll go into more later. So we'll go to the next slide now, Paul, if we can. In the internal nasal valve, which Judy also talked about, again, that septum has to be right down the middle. If where the red cartilage, which you see here in this picture below, the upper lateral cartilage, where that meets the septum, which is the green part in that model, if that's too narrow, you can imagine if you built a tent and you had the central tent pole being 20 feet high and the canvas flaps being much too narrow, when a breeze comes, it's going to collapse inward very easily. So we need to make sure that it's a nice wide angle where the upper lateral cartilage meets the septum. And so we'll widen that with grafts that I'll show you in a minute to make sure that air can get in more quickly. And then also augmenting the upper and the lower cartilages to make sure that, again, they don't collapse inward. And then lastly, the sidewall of the nose, where you can see the red part there, making sure that also doesn't collapse when you breathe inward. So we'll move on to the next one. So now going back to the external nasal valve, what kind of options do we have surgically after you send a patient to the facial plastic clinic? So on the left picture, in the lower left-hand side, you can see those two ring-like cartilages. So those are also taken from the septum, or you can take them from the rib, you can take them from the ear, anywhere you can borrow cartilage, and you place those in a pocket that you create along the alar rim. That prevents cartilage collapse and valve collapse and helps the patient breathe better. So now moving on to the internal nasal valve again. So some options to surgically correct that valve. So once again, if you ensure that the septum is in the middle, if you look at the picture in the lower part of your screen on the left side, of course that patient's caudal cartilage, caudal meaning closer to the lower part of the nose, that's deviated well into the patient's left-sided airway. If you saw this patient in your clinic, they could use a referral to the facial plastic service, because we can bring that septum back to the middle and make the valves once again nice and symmetric and get air into that more easily. So another option to ensure that the septum's in the middle. So after patients say if they've broken their nose, or if it either last week or 10 years ago, it doesn't matter, and the nose is deviated off to one side, it's going to be hard to get air in through a very asymmetric nose. And so one trick that we have is we can actually remove almost the entirety of the septal cartilage and rebuild their nose, including this part of the nose and the lower part of the nose, leaving an L-shaped piece of cartilage extending from their face. And that way air can get in both sides, and the left and the right side, more equally. So we can go to the next slide as well. And we do that partially with these grafts you may have heard of. They're called spreader grafts. And they're called spreader grafts because they spread the upper lateral cartilages from that central cartilage, or the anterior part of the septum. So again, that goes back to that angle where the upper lateral cartilages meet the septal cartilage in the middle. So if that angle is too narrow, as soon as they try to breathe inward, it's going to collapse downward, and they're not going to get any air in past their internal nasal valve. And the internal nasal valve is the narrowest part of the airway. Once again, if you have any questions out there, don't hesitate to ask. But these spreader grafts are helpful to place along either side of that dorsal cartilage, the septal cartilage, and then we reattach the upper lateral cartilages, which you can see there in the picture on the right, to those spreader grafts. And now when the patient breathes in, it no longer collapses downward. So it's almost like if you can see an arch made of stone, adding another piece of stone to that arch to widen it so that it can fit more air in. So that's a very important graft that we use often in functional rhinoplasty after a patient is referred for inability to breathe through their nose. So then we have a series of grafts here too that help to prevent the outer part of the nose from collapsing inward. So if in your clinic a patient's complaining of difficulty breathing through their nose, and you watch them take a breath inward, and you notice that the sides of their nose collapse inward when they breathe, that could be contributing to why they can't breathe well through their nose. Again, contributing to poor sleeping, snoring, poor exercise tolerance, and so on. And so what we do is we borrow some cartilage, again, most often from the septal cartilage deep inside the nose through incisions that are hidden inside the nose. We borrow that septal cartilage, which is usually deviated into one side of the airway or the other, and we use that to make these grafts, which support the side wall of the nose so they can breathe better. And so on the lower left-hand part of your screen is what's called an alar batten graft. And that supports, remember, the internal nasal valve, which is the narrowest part of the airway. It supports that side. We place just the edge of it over the bony part of the face so that it doesn't collapse inward. And so when they breathe in, when previously they were collapsing in, now they no longer collapse and then get more air in their nose. And so in the middle picture there, you have what's called the lateral crural strut, which is the type of graft is not important to this discussion, but again, that prevents the nose from collapsing. So when they breathe inward, they get more air in, they stop snoring, and they can sleep better, and so on. And then finally, the lower right-hand part of your screen is what's called a butterfly graft. That's often taken from cartilage from the ear. And again, all designed so that when the patient breathes inward, no collapse, they get more air, and the rest follows.
Awesome. Thanks, Jeff. That's a great insight into our some of the surgical techniques and options that are available to us. We actually had a great question from one of our colleagues in Brooklyn who was asking us about, you mentioned looking at patients' noses when they breathe in the clinic. And Judy mentioned the modified column maneuver. Are there, the question was, can you give us 2 or 3 kind of pearls about things that we can look at in the primary care setting that might prompt us to refer sooner or later for people who are having difficulty with breathing through the nose? Either Judy or Jeff, do you want to take those questions?
I think for the patient who's coming in with nasal obstruction as the complaint, one of the things that can tip you off that maybe this requires more structural work is if they have a crooked nose, one that is tilting to one side, C-shaped. I think crooked nose will sort of be a tip-off that there might be more structure that needs to be corrected to improve their nasal obstruction, in addition to the visible collapse that you may see on either nostril. Certainly, if you are looking into the nose and you are using the otoscope or a light source and see that the septum is severely deviated, just doesn't look right to you, looks like it's all bent up and crumpled, those would be reasons I think that you might want to refer.
Great.
And one thing I'd add to that is if a patient complains of not being able to breathe well through their nose, if you block one nostril and watch them breathe in, sometimes you can see right where the nose meets the side of the face, if that really collapses inward easily on the side that's not blocked, they may benefit from one of these grafts that we mentioned. Same thing on the other side. You block the nostril, watch them breathe in, and then they collapse downward. It may benefit from some of these procedures that we've been talking about, and they may benefit from a referral.
Perfect. All right, thanks, Judy and Jeff. The division between external and internal nose is ultimately probably a little bit artificial, but I think it is good for us now to have our rhinology colleagues talk to us a little bit about some of their considerations when they're thinking about the inside of the nose. Obviously, all of these specialists think about the nose altogether, but there are a lot of unique considerations that arise when thinking about structures internal to the nose. So Dr. Lieberman, I think, is going to head us off in that direction and thinking about the rhinologist perspective on these issues with nasal obstruction.
Oh, I'm just gonna add one thing if I can before Seth starts for clarification. And I think that Jeff and Judy mentioned this in sort of talking about starting out with a straight septum. But I think the point is not that the facial plastics people do just this external work and the nasal and the internal and external nasal valves, unless something's been done to the septum where it's already straight or the turbinates have been reduced. As a general rule, that's the starting point for most people who have nasal obstruction, and then these things are kind of supplemental to that, if I'm not misspeaking on their behalf. So these are not mutually exclusive, as you sort of alluded to, the internal and external nasal problems.
Yeah, thank you. I appreciate that perspective. Nonetheless, we will proceed with the second half of this presentation as it's organized currently to look at some of those internal considerations.
Thanks, Paul.
Seth, over to you.
Great, thanks, Paul. So we're just going to go over some of the structures that are inside the nose, which are really things that you can't see without an endoscope mostly. And it's important to have an understanding because there's a lot of different culprits for what can cause nasal obstruction. So just some very basic anatomy. We have sets of turbinates in the nose. The ones that you can actually see with an otoscope or just a headlight is the inferior turbinate, and this is a very common problem for causing nasal obstruction. But there's also a middle turbinate. There's a superior turbinate. There's the areas where the sinuses drain, which is the middle meatus and sphenoethmoid recess. These are the areas where when you get infections, pus is draining from these areas, or this is where polyps oftentimes start. And then there's the area way in the back, which is the nasopharynx, where the adenoids sit. And so this is, that's definitely an area where you'll never see without an endoscope. Okay, you can go ahead. This is just a picture of the nasopharynx way in the back of the nose. That little opening on the right side is actually the eustachian tube opening. And that's why you oftentimes have people who complain of eustachian tube issues in addition to problems in their nose. This is just showing the three sets of turbinates, but you can go past this. So this slide and the next slide are a nice demonstration. This is obviously a coronal CT scan. And Paul, if you could just point out the inferior turbinates there. That little thin black area around this is the airflow. So that's where patients are breathing. And if you go to the next slide, and maybe you can flip back and forth, you can see the difference between a hypertrophied inferior turbinate and a normal turbinate. And so, in the first slide, the patient has a little bit of a deviated septum, but really the main issue is that turbinate hypertrophy. You can see all that thickened tissue between the outer lining and the bone. So this is the point of this slide, is just to talk about, there is a subjective sense of breathing. And when you think about people who use Vicks Vapor Rub, or if you've ever smelt horseradish, or when you eat wasabi, you feel like your nasal passages are just opening, wide. But in reality, it's really just stimulation of trigeminal receptors in your nose. and breathing in Vicks Vapor Rub does absolutely nothing in terms of changing the structure of your nose. So there is a sensory component of it, and rarely, but sometimes, that's the issue in terms of patients' complaints of obstruction or congestion. And when you have a little bit of swelling in the nose and two areas of the lining of the mucosa in the nose touch, that can give you, a really big, a really significant sense of obstruction and discomfort. So, one of the main parts in terms of, determining the cause is you need to find out if there's any associated symptoms. And so this can give you some of the warning signs, especially for that rare case of where somebody has a sinonasal tumor or something like that causing a problem. So if somebody's having, copious bleeding, if they're having any physical exam findings that are extra sinus findings like eye swelling or visual changes, these are very concerning issues. But for the most part, to differentiate things from allergy versus sinusitis, you want to find out about other associated symptoms, facial pressure and pain, how their sense of smell is, if they have a cough, if it's unilateral or bilateral. So these things are all important in terms of figuring out the diagnosis. So temporality, which is a word, in fact, that really, this is one of the main ways that we sort of figure out what's causing the problem and how to help people. You want to find out, are there symptoms, when they're coming in to see you, this symptom, they talk about it like it's been going on their whole life. But in reality, it may only be going on for a week, or it may just be seasonal. Sometimes these things only happen at nighttime. That can happen when you lie down flat. And as with anything that gets closer to the heart, you can get some swelling inside the nose. If symptoms are mainly in a season, such as the winter, when the average adult gets about 2 to 3 upper respiratory infections, you have to think about that this may just be recurrent URIs. You always want to find out about recent life changes. Have they recently got a dog? Their child just going to daycare? These are real hazards for patients' health in terms of being exposed to viruses or new allergens. Any changes in terms of their work environment or in their home, which could determine whether there may be some sort of environmental cause.
Seth, we had a great question come in from one of our colleagues here in internal medicine at Kish, who found the CAT scan images particularly instructive, and wondered, said, I look in noses often and can't tell if turbinates are indeed big or hypertrophic. How do you have some sense of that, and just decide if turbinates are indeed big or hypertrophic? Again,
so we have the advantage of having flexible scopes, so we can really look at the entire turbinate. But you can, just with the otoscope, take a look just in the front of the nose, and here's a nice demonstration of a hypertrophic and inflamed turbinate. If you look right in that nose, if you even have a nasal speculum and a light, and you really spread those nostrils, you can see the head of the inferior turbinate. And this can give you a lot of clues as to what's going on. And so here what we're looking at is the inferior turbinate, the nasal septum. And you want to look at, what's going on around that turbinate, because the airflow is going to be below the turbinate, medial to the turbinate, superior to the turbinate. And so if it's swollen and it's touching the septum, or if it's all the way down to the nasal floor, as it pretty much is in this picture, then you know that that's probably an issue. These are oftentimes can be very swollen and bulbous. They're oftentimes confused with nasal polyps. Oftentimes patients are sent to us and told that that they have nasal polyps when really they just have a swollen turbinate. And you can also
jump in if I can for one
absolutely.
second, add something to that, that people may not be aware of. This picture, more so than the smaller turbinate picture, demonstrates it nicely, and that is that the turbinates go through what's called a nasal cycle over the course of the day. So one turbinate will normally be larger than the other. The patient is generally breathing more if you were to measure it through one side of the nose than the other, but if everything's working well, they're not really aware of that. So if you're getting a CAT scan at any given point in time or looking in their nose, you may see one turbinate that looks large relative to the other, and that's not necessarily abnormal. In fact, it is part of the normal physiology of the nose. And the bottom line, as I think Seth demonstrated nicely with some of the pictures, is that it's not a wide open space, the nose. There's supposed to be a degree of obstruction and a relatively narrow space for air to flow and to create turbulence. So, the size of a turbinate isn't very meaningful in the absence of a complaint of nasal obstruction. So we're starting, from the point of a patient having a symptom, and you have to also, understand that, and then the fact that you're seeing things at one point in time. Even without an endoscope, if someone were so inclined, you could spray a little decongestant spray in the nose, some oxymetazoline or Afrin, and then look in the nose just a couple of minutes later, and it will look very different if you really did want to get a better look into the nose and to see if that made a difference in terms of the patient's symptoms, and also if that thing that you're looking at in the front of the nose is actually the turbinate, because polyps and tumors and things along those lines don't decongest. So it's a relatively simple thing to do, and also just some things to keep in mind.
Perfect. Thanks, guys. And so we spend a lot of time ultimately, I think, as ENTs looking at inferior turbinates, but Seth, you also mentioned that as we know, there are other turbinates. So how do those sort of factor in to your thinking and some of the management here?
Right. So you can have pathology of some of the other turbinates. So really, the middle turbinate is the only other turbinate that can potentially cause some nasal obstruction. You can see here on the CT scan what's known as a concha bullosa. So this is a pneumatized middle turbinate where you actually have an air cell within the turbinate. It's somewhat controversial. This in isolation is probably not going to cause somebody's main symptoms, but it could be a component of it. And you can also get, so in terms of what can happen from the sinuses or from the areas where the sinuses drain, this is where you're going to start to see the polyps and some of the pathology that grows out from the sinuses or from the meati and can fill the nasal cavity. And this is where you'll get your tumors and your polyps. And you can see what a polyp looks like at that slide on the upper left, sort of water balloon-like lesion there. That the lesion that we're looking at with the nasal speculum, that may be an inflammatory polyp. That could also be a tumor. That's what a tumor can sometimes look like when it grows and fills the nasal cavity and comes out all the way to the nostril. Sometimes polyps do that too, and you can basically see a polyp when a patient walks into the room. And then, again, I'm just going to point out what can go on in the nasopharynx. If you go to the next slide, you can see what adenoid hypertrophy it looks like. Usually you would see this in the younger population, usually in the pediatric population, as this tissue generally involutes as you get older. But sometimes, patients, especially who are reacting to something, who have allergies or some other exposure, can have adenoid hypertrophy, and this can be the main issue. And this is something that you would never really see as a relatively easy fix in terms of surgical cure. But this is what you would see on an endoscopy when you're looking all the way back in the nasal cavity.
Yes, we do get that question a lot from colleagues, I think, or maybe not a lot, but people do often talk about adenoids. How often do you see them in adults, and is that something that should be on the forefront of people's thinking in the primary care setting?
It's pretty rare, but you'll see it in patients who have a high burden of allergy. You'll look back there and you'll see some hypertrophy. Rarely does it get to what you see here on the screen, but sometimes you can. If you see an exam like what you see on the screen, you have to start worrying about lymphoma or some other neoplasm.
Yeah, I think that's a good point. Not to make these things alarming, but there are situations where nasal obstruction is due to real pathology, and I think the general rule is that adults, late teens and later, don't have adenoids. And so if you see significant adenoid hypertrophy, that's something that should be evaluated and in the setting of the patient's overall clinical picture, and whether that's something that may be pathologic. One of the other interesting things about nasal obstruction at that level, at the level of the nasopharynx, is it tends to affect the voice more because, and Paul, you probably know this better than I, but nasal resonance comes from the back of the nose, obviously, and patients who have obstruction at that level tend to have that hyponasal voice. And when you hear that, you might not see the reason for it on an anterior exam, but it suggests something further back, and that's something that might warrant an endoscopic exam. Whereas patients with more anterior obstruction, as stuffy as they may be, they don't have that hyponasal sound quite as much.
Yeah, I think those voice clues can give us a lot of information into what might be going on at the back of the nose. We've talked a little bit about how you mentioned the Afrin test and ways to diagnose the contributions that the internal nasal anatomy will make to nasal obstruction. Can you tell us a little bit more about that and kind of what you think about when you're trying to pinpoint or isolate some of the etiologies of nasal obstruction here?
Yeah, sure. Yeah, so as Rich said, spraying Afrin actually can be part of our physical examination, because what Afrin does is it basically removes the swelling from the inferior turbinates, or even the septum can get swollen. And so it sort of removes those issues as factors for causing the nasal obstruction. And so examining patients and sort of asking them how they're breathing before and after Afrin decongestion will help to determine what the cause is. So, and again, a lot of it's common sense. So, I just put that example of a patient who has, a deviated septum to the right and inferior turbinate hypertrophy. If you give them some Afrin decongestion and they still have, left-sided obstruction, you have to ask the question, why? What's the issue? And sometimes you have to look more externally, which should be part of the exam. Are they having nasal valve collapse or whatnot? So it just sort of helps us to have an algorithm and a logical way of looking at what the diagnosis is.
Seth, we just got a question from one of my colleagues at the Westside practice. So is this something that primary care physicians should consider doing in the outpatient setting, Seth or Rich? Is it worth having some Afrin around and doing this test? Your thoughts about that?
I think it's an easy enough thing to do. I wouldn't say it's obligatory. I mean, for the most part, patients who have nasal obstruction, you can assume it's a combination of their septum, their turbinates, and then maybe some of these internal and external nasal valve problems. And for the most part, starting with a simple topical nasal steroid spray and seeing how they do is a reasonable starting point. However, I think the Afrin test is probably most useful in the setting of seeing something in the nose and not being sure what it is. And I think that we've all seen patients who were referred for a questionable polyp or mass in the nose that ends up being an inferior turbinate. And so if someone were wanting an easy test in their office to know if that structure that they're seeing in the front of the nose is actually just the turbinate, then the 2-minute Afrin test would pretty readily answer that question.
Yeah, Rich, you alluded actually to first-line management, and I know you guys are planning on talking about that, so that's a nice segue into how do you decide what to do empirically or how to start with these patients who have perhaps inferior turbinate hypertrophy that may be at the root of their nasal obstruction?
Well, honestly, in this day and age, a lot of the stuff on this slide isn't really our starting point, because patients do this on their own. I mean, basic allergy and rhinitis, non-allergic rhinitis management is pretty much available over the counter now. So the antihistamines that we used to prescribe are over the counter, and the topical nasal steroid sprays that we used to prescribe are now over the counter. And patients love to self-diagnose their nasal problems, sinusitis, allergy, etc. And so I would say that a good number of patients have already done this on their own. But had they not, my initial treatment is a topical nasal steroid spray as first line, and then an antihistamine added as needed if the symptoms sound allergic and or if they're known to be based on testing.
Yeah, I'd love to hear from our facial plastic colleagues a little bit about their thoughts about this medical management as a precursor to or a requirement for surgical management? Do you insist on control of the mucosal forces that can contribute to nasal obstruction before you will operate? What are some of your thoughts about that, either Judy or Jeff?
Absolutely. I would say that especially for the patient who has sort of waxing and waning symptoms, it sounds where you might be concerned that this is more of an inflammatory issue. I certainly encourage and almost require most patients to at least try, topical nasal steroid sprays. Also, consistency is helpful. Sporadic use of the spray, not nearly as helpful as consistent use. So I'll usually place these patients on nasal steroid spray for a month and see whether or not they notice any valuable improvement. If they didn't, which oftentimes our patients don't, then it leads to more of a fixed obstruction, one that doesn't depend on inflammatory factors. And so for me personally, I think it's helpful to have this first, almost as a rule out type of situation.
Yeah, Jeff, any thoughts or
I agree with that. But that being said, if a patient has a crooked nose and has a narrowed valve and they come in and it's obviously there's anatomic obstruction there, well, obviously mucosal disease is not the likely culprit. And so I think there I would proceed directly to surgery. But often, just like Dr. Lee said, if it's waxing and waning, if it's worse during allergy season and so on, that we try everything we can non-surgically before offering a more invasive measure.
Good. Right. So thank you. We did explore some of the external, the infrastructural surgical approaches to helping with nasal obstruction, but I know the rhinologists often do a lot of procedures on the turbinates themselves. So Seth or Rich, can you talk us through some of what is involved with that for our colleagues who may not actually know what a turbinoplasty is?
Yeah, sure. So in patients who have, failed medical therapy, they've been, tried on at least 4 to 6 weeks of a nasal steroid spray, and they either don't tolerate it or they haven't, they're still not breathing well, and that's clearly the issue. You can perform a turbinoplasty, and there's some procedures that you can perform in the office, and there's some that you can perform in the operating room. This is just one example of what's known as a submucous resection. So you're removing that thick stromal tissue inside of the turbinate, the stuff that swells, it's almost like erectile tissue, through a little incision in the front of the turbinate. And you can see the before and after pictures, and it has a very long-lasting result. And it basically just opens up the airway around the turbinate.
I think that's a great description. I think the best way to explain it to patients is that it's essentially the surgical equivalent of Afrin, especially if you've just sprayed Afrin in their nose, because most people have used Afrin at some point and they know that it helps them breathe better, but they're not really sure why. And you can explain to them that essentially what it is doing is reducing the soft tissue volume of the inferior turbinate, and that's what a turbinoplasty does as well.
Guys, can we talk about Afrin just briefly as we get close to the end? But that is a commonly used over-the-counter remedy for this. Can you just, for our colleagues, just describe why that causes some angst in our world?
Why it causes problems?
Why it causes problems, and why we caution patients about prolonged use.
Sure. So, it's not a bad medicine by any means. The problem is most people, some more than others, and I've had occasional patients who don't seem to have this problem, but develop a rebound effect. And there are a couple of different theories on why that happens with use of Afrin for longer than the 3 to 5 days that's recommended in the extremely small print on the back of the bottle. And that's really why we caution against it. So what happens is patients end up, the term Afrin addiction is used, but rhinitis medicamentosa is really the proper medical term. But what happens is the effect of the Afrin over time becomes less and less, and the duration of that effect becomes less and less. So you'll have patients who are literally carrying bottles of this around. They have one in their car and on their nightstand, and they're spraying it up to, I've seen several times a day just to be able to get any relief. And that is the problem with longer term use of Afrin. And it's difficult oftentimes to get them to stop. And sometimes the only way really is to do a turbinoplasty, but I do try to get them at least to minimal Afrin use before offering that.
Yeah, the struggle is real with Afrin often in many patients. We had a good question from one of our internal medicine colleagues about the role of imaging in workup of nasal obstruction, and when to consider, is it their role to get a CAT scan, when to think about how and when to do that. Seth or Rich, any thoughts about that?
Yeah, sure. So, people oftentimes come with sinus CAT scans as part of a workup. And, we put a lot of thought in terms of when we get a sinus CAT scan and what we're trying to answer. I get CAT scans when I'm trying to answer a question, or when I've sort of come to a point in a decision tree, whether I need to go one way or the other. Again, we have the benefit of looking in the nose with endoscope, so we can, make diagnoses without CAT scans in terms of sinusitis or nasal polyps. The times when I'll get a CAT scan for a diagnosis is when, I'll do an endoscopy that's negative, but that doesn't necessarily rule out a sinus issue. And I want to actually take a look into the sinuses, which we can't see with the endoscope. Also, obviously, if there's any risk of somebody having a tumor, or if you just can't get a good exam on them because they don't tolerate it, or if they're extremely swollen, a sinus CAT scan will help.
Yeah, I would agree with that. And I think, I don't know if the plastic surgery colleagues on here use it to look at the structure of the nose so much, but in rhinology, it's basically not something we use unless we're considering the sinuses as part of the problem. So for nasal obstruction, basically, a good decongested nasal endoscopy can answer the questions that need to be answered along with the examination of the external nose. So, we get them, at least I generally get them if there's an issue or question about an issue with sinusitis.
Judy or Jeff, any thoughts about imaging in your thinking and workup?
I would say that for typical external nasal obstruction, internal nasal valve, external valve, deviated septum, those are things that can be readily seen on exam, and actually are seen better on exam because it's dynamic with them breathing. So CT is not as helpful in that. However, I do get CAT scans sometimes for surgical planning, especially in revision cases, but also sometimes you can pick up things like a concha bullosa or an enlarged middle turbinate that may not be quite as obvious to me in the exam, in the office exam. And then also if there's any questionable history of a more chronic inflammatory condition on top of that, I'll get CAT scans.
Yeah, good. Jeff, any thoughts?
Completely agree. If there's some concern that with recurrent intermittent sinusitis or chronic sinusitis, kind of general ambiguous nasal congestion, I'm not quite sure about, the CT of the sinuses could be helpful, and maybe a referral to my rhinology colleagues at that point too.
Very good. Seth and Rich, you put in this slide, which I think is an interesting point, a sick CT excuse me, versus a well CT. Can you tell us a little bit more about what that means and what's involved in that thinking?
Sure. So, timing of a CT scan is important because if you look at a scan of somebody who has chronic sinusitis and somebody who has just a really bad cold, you wouldn't be able to tell the difference between the two CTs. So you need to listen to the patient's history and take everything in context. And so if a patient has, recurrent sinus infections, and so when they get a CAT scan, you want to know, are they having an acute episode or are they well? Because showing inflammation when they're well will be significant versus when they're sick, or a patient with chronic sinus infections.
You introduced this topic about sinus infections, which is probably an entire other webinar unto itself. But how do you think about chronic rhinosinusitis or acute on chronic rhinosinusitis in the context of nasal obstruction, and how you consider imaging and evaluation and diagnosis and management?
Well, certainly is another topic altogether, but definitely not something that is entirely separate from what we're talking about. obviously patients with severe chronic rhinosinusitis, and as the name implies, it has a nasal component as well. And once you start to get into situations like this with polyps, the nasal obstruction can be a primary complaint, or even the only complaint, other than maybe loss of sense of smell, that a patient with a really impressive scan like that may have. One of the things I would just point out in bringing up this topic is that we started this talk by calling this the blocked nose, and we've used the term nasal obstruction and whatnot. The term we haven't really used much, but that patients use a lot, is congestion, and it's kind of like the dizziness of the nose, and it means a million different things to different people. And sometimes it's sort of a pressure and a lack of clarity in their paranasal sinus region and face. Sometimes it's clearly nasal obstruction, but I've been surprised how often a patient will be talking about congestion, and I will ask about breathing through their nose, and they will say, well, I have no problem breathing through my nose, I'm just congested. And so it's kind of a little bit of a trap in terms of maybe separating some of the sinus and nasal symptoms. And it's something I always sort of try to clarify before deciding what's going on.
Totally fair. And, again, as you say, Ryan, sinusitis is a topic unto itself. Do you want to just mention this, since it's here, as sort of first line management and some thoughts about that, and how to think about, because I'm sure a lot of our colleagues in primary care do see patients who have nasal congestion, as you say, Rich, which may be, the root of it may be chronic sinus disease. So maybe give us some pearls about how to manage sinus disease just before we go.
Yeah, well, I think if we get back to one of Seth's earlier slides and diagnosis, the real trick with treating sinusitis is diagnosing it. It's not generally that difficult to treat. Obviously, the more recalcitrant chronic variety being a bit of the exception, but it is probably, I don't have statistics to back this up, the most overmade self-diagnosis in medicine. Everybody diagnoses themselves with sinusitis, and it's very easy, much easier in fact, to just go along with that diagnosis and treat it. And I think what Seth put up here in terms of kind of standard initial medical management is right on target. But I think the problem with the antibiotic piece of it is that it's just overused, because acute bacterial sinusitis is overdiagnosed, and there's very good evidence that the vast majority, over 90% of even bacterial sinus infections will get better without antibiotics. And so I think one of the things that I like to think about and talk to patients about and try to get them to buy into is that we don't always have to use an antibiotic, and that doesn't mean we're not going to treat them. It just means we're not going to necessarily treat with an antibiotic. And so that's what I would say about that, is that I don't jump right to the antibiotic. But if you do, those are good ones to use. And that's my 2 cents.
Thanks, Rich. I know that's a common topic of conversation among our primary care colleagues. This hour has really flown by. Thank you all for your questions, audience members, and most especially thank you to our panelists who have given us a really comprehensive overview and tour through this topic that is, as we, I think, have seen from today's panel, incredibly complex, subtle, and nuanced. And so we are certainly happy to be a resource to you as colleagues in the Department of Otolaryngology and Head and Neck Surgery. The contact information is listed here. We're easily findable through email or by phone. Most especially, again, we are here to be a resource to you and to assist you in managing these patients with this very common but often complicated problem. Thanks everyone very much for joining us. Have a great evening. I'm sending our best regards from Manhattan. Thanks and good night.